Ladies and gentlemen, we're going to go ahead and get started. If you want to find your seats, please. Welcome to the second semifinal debate of the 2007-2008 National Public Policy Forum. We just heard a terrific debate with Colleyville Heritage and Wellington High School. Congratulations to both of those teams. And we are now moving into the second semifinal debate, which has Kahuku Intermediate and High School of Kahuku, Hawaii, thus the Lays, taking on Bellaire High School of Bellaire, Texas. They flew a lot of people over from Hawaii, huh? Kahuku is coached by Winnie Graham. And today's debaters are Rebecca Hurst, Anna Reedy, Nick Serlin, and Sarah Ungerite. Bellaire is coached by Russell Rock, and today's debaters are Jenny Fan, Andrew Garbarino, Vijay Kashaw, and Satish Vamuri. Best of luck to you. And now to introduce our moderator to you and our judges. I think you were with us earlier today. We have David Baker as our moderator, our distinguished panel of judges, Will Baker, Marshall Donat, Luke McGrath, Tuna Snyder, and Pam Spiliadis. So at this point, I will turn it over to Mr. David Baker to get this underway. Good luck to both teams.
Thank you very much, Kit, and welcome to both teams, and welcome back to those of you who are in our audience here or have joined us online. I will remind everyone, including the panel, that the two teams involved in this debate did not pick the sides on which they are debating, and we would ask that you remember that as you evaluate the arguments, and remember that the evaluation of this panel will be based on the clarity of argument, evidentiary support, depth of analysis, refutation, and the quality of their presentation. They did not have any choice on the sides they are debating today. I will also ask the two captains to help me. The less I talk, the better this goes, in sort of making sure that questions and answers are distributed somewhat equally. I will be keeping track of that, but we want to make sure that everyone gets to participate. I was asked a question earlier that in the original format, it does say that that the captains do not participate in the first cross-examination period. Of course, we have 4 people on each team now participating, which we normally do not have. So I will distribute those. Everybody will either have a question or an answer, one of the two, in that team cross-examination period. And then once we get to the judges' cross-examination period, it's pretty much no holds barred, right? Yeah, okay, that's pretty much what I thought. I'll make sure that the answers are distributed somewhat equally. When we get to a reasonable stopping point, we'll stop. We will then have the 2 5-minute rebuttals, and then we'll be all done. So have a great time. Enjoy yourselves. Relax. It's a very friendly panel, right? Look at them. Look how nice they are. No reason to be afraid of that. Since we've already established that we have cheerleading sections on several sides, this could be a lot of fun. So we will go ahead and start with the affirmative opening statement for 10 minutes. Anna, I believe that's you. Go ahead.
Good afternoon, everyone. The affirmative team advocates that in order to truly have a positive, significant impact on the AIDS-HIV crisis in sub-Saharan Africa, we must shift our focus from solely working to treat patients and prevention, but we must improve the system we use to treat patients in. Only the African Health Capacity Investment Act provides the healthcare infrastructure and management needed to improve the availability and quality of healthcare in the region and effectively tackle the AIDS crisis, which is why we stand resolved that the United States federal government should substantially increase its AIDS assistance to sub-Saharan Africa by implementing the African Health Capacity Investment Act. We entered the new millennium with 24 million infected with the virus. By maintaining the status quo, nearly all will die by 2010. Each day, 6,000 Africans die from AIDS, and each day, an additional 11,000 are infected. Other nations are beginning to feel the effects of AIDS, but it is nowhere close to the problems as in sub-Saharan Africa. Senator Durbin explains, with 11% of the population, 25% of the global disease burden, and nearly half of the world's deaths from infectious diseases, sub-Saharan Africa has only 3% of the world's healthcare workers. Personnel shortages are a global problem, but nowhere are the shortages more extreme, the infrastructure more limited, and the health challenges graver than in sub-Saharan Africa, the epicenter of the HIV/AIDS pandemic. We will not win the fight against HIV or AIDS until we find a solution to this severe crisis. According to the World Health Report, the shortage of health personnel, including doctors, nurses, counselors, and paraprofessionals, is the leading obstacle to fighting HIV/AIDS in sub-Saharan Africa. The emigration of large numbers of trained healthcare professionals from sub-Saharan Africa to other Western nations undermines the billions we spend in national and international efforts to stop AIDS through medicine and prevention in the status quo. The United Nations Special Session on AIDS reports that one of the biggest challenges to fighting AIDS is the lack of clinics. They most desperately need the creation of working healthcare systems. This is because clinic infrastructure is often in disrepair and lacking the most basic functions. An assessment done in South Africa showed that only 1/3 of the existing clinics had electricity, and in half of those, the supply was erratic. Only 8% had telephones or running water. It is vital. Improving the health care systems is vital to solving the HIV/AIDS epidemic in sub-Saharan Africa. Therefore, it is imperative that the African Health Capacity Investment Act be passed. Studies unanimously indicate that African doctors and health professionals would prefer to stay in their homeland of sub-Saharan Africa if only there were more job opportunities and they were able to make a living. Our act would alleviate the problems facing healthcare workers by increasing salaries and benefits of healthcare professionals, improving working conditions, improving management of healthcare systems and institutions, and increasing the capacity of health training institutions, which would greatly reduce the immigration of healthcare professionals from the continent. For example, Partners in Health has been operating clinics in highly impoverished regions crippled by some of the worst health incidences in the world. PIH uses a similar strategy to what would be set up under the Act. The program has received acclaim in retaining doctors at its remote clinic sites and reducing the crippling effects of the brain drain in the region, and how it has affected the healthcare in the region as well. These projects have helped to decrease the severity of the HIV/AIDS crisis in the area. In another example, in 6 months under the control of Josh Ruxin, co-founder of the Access Project, Access was turned one clinic with no patient records, no accounting system, and about 5 patients a day into one that sees 100 to 150 patients a day and is actually able to generate income. According to the Global AIDS Alliance, the Act, by creating better and safer working conditions, would help prevent an additional emigration of over 20,000 African healthcare workers each year. This number will continue to grow as international donors work with the United States. A unique advantage to the affirmative plan is that it creates sustainable systems for Africans themselves to operate. Thus, even after the African Health Capacity Investment Act has expired, the benefits will continue to grow. To address the negative attacks, the negative argues that there will be a brain drain within sub-Saharan Africa itself. However, our act has specific provisions to counter the disparities in health personnel distributions. The negative claims that giving assistance to Ethiopia will signal U.S. indifference to their human rights violations. But this is simply not true. The President, within the parameters of the Act, and with approval by Congress, can decide where funds should go in sub-Saharan Africa. Thus, the President can decide not to give funds to Ethiopia if it would worsen the war in that region. Also, because Ethiopia is currently a PEPFAR-focused country, it is already receiving aid in the status quo, making this disadvantage not unique to the affirmative plan. We are topical because we are substantially increasing assistance by creating a sustainable health management system that Africans can rely on. Currently, no U.S. funding is going towards infrastructure and management. A $0 to $600 million increase is substantial. Our act also enables the United States to more effectively and efficiently utilize the billions we spend on HIV/AIDS now. Thus, we are clearly topical. The negative has asked you to evaluate the debate based on who gives a better plan. The negative's counter-proposal, which only aims to train community health workers, does not address Africa's poor health infrastructure and management. The people of sub-Saharan Africa will still be receiving inadequate care because the health systems in sub-Saharan Africa are in such disrepair. Without this critical change in the health systems, the community health workers would have no incentive to stay in the region after they've received their training. Furthermore, the negative does nothing to retain doctors or nurses. As demonstrated earlier, it is these doctors and nurses that are key to solving the HIV/AIDS virus. The second part of the negative counterplan is to disband PEPFAR, but PEPFAR has been an essential actor in the fight against HIV/AIDS. It has prevented over 150,000 infant infections, administered ARV treatment for almost 1.5 million people, and has supported the care for more than 6.6 million. PEPFAR has been key in significantly decreasing HIV. The only problem with PEPFAR is that it lacks the essential healthcare systems to run efficiently, which we provide through our plan. The negative counterproposal seeks to stop PEPFAR's abstinence, be faithful, and use condoms, or ABC policies. Yet disbanding PEPFAR and putting it under the control of US aid will not change the ABC policy in any way. According to the negative constructive, even the World Health Organization itself employs the ABC policy, but simply under a different guise. But to make this extremely clear, our bill is outside the scope of PEPFAR and the ABC policy. The African Health Capacity Investment Act targets health infrastructure and management, which is completely different from the ideological policies in PEPFAR. The two programs are different, but can coexist together and complement each other, as our act increases PEPFAR's efficiency. The negative says the counterplan is better because it will help to improve US relations. However, the African Health Capacity Investment Act does foster good relations with the European Union and multiple international organizations. It accomplishes this by coordinating and working together with these organizations to reach its desired goals. The affirmative will not draw funds from other regions of the world. Both plans acquire funding through deficit spending, yet the negative seeks $7.4 billion more. Taking $8 billion is a far greater financial burden on the United States than our proposed $600 million. The negative argues that the World Health Organization would be better than the US at solving the plan. Yet the World Health Organization has been proven ineffective in combating global disease problems in the past and is ridiculed for medical misjudgment. The World Health Organization has shown to only care for wealthier nations, which is clearly not sub-Saharan Africa. None of these problems have changed since the analysis was reported. They have also provided no evidence that the World Health Organization has been efficient or will be effective at implementing this massive worldwide plan. The United States is expected to pay for this $8 billion plan, and they expect that the United States will not be controlling it. The US is known to give aid with strings and could still easily control this. The negative proposes an increase in only community health workers and fails to recognize the superior quality of healthcare infrastructure and management provided for under the Act. The impact of the African Health Capacity Investment Act on sub-Saharan Africa is immense. By providing qualified doctors and nurses and providing for all the oversight which we have stated earlier, we can help to save millions of lives. Thus, this plan must be passed. Thank you.
Thank you. The opening statement by the negative.
Before I begin, I would like to thank the Bickel and Brewer Law Firm and New York University for hosting this event and providing for our stay in New York. Specifically, we would like to thank William A. Brewer III and John W. Bickel II, Travis Carter, Kit Sawyers, Kristen Miles, NYU President John Sexton, and the NYU debate team. We would also like to thank our judging panel, Mr. William Baker, Mr. Marshall Donnett, Mr. Luke McGrath, Mr. Tuna Snyder, and Ms. Pam Spiliadis, as well as our moderator for today, David Baker. We also thank our coach, Russell Rock, and lastly, we thank our worthy opponents from Kahuku High School for an enjoyable and spirited debate. Today's discussion is about two competing policies. One, a piecemeal regional solution administered by the United States, and the other, a globally orchestrated effort. The affirmative proposes to increase community health workers in Africa through a US-administered program. We, the negative, propose to increase community health worker numbers through a program administered by the World Health Organization. The WHO Health Worker Program is a superior policy in this round. The proposal, as outlined by the World Health Organization, calls for training community health workers in all countries impacted by HIV, including India, Africa, Southeast Asia, South America, Russia, and China. Several of the affirmative author advocates admit that World Health Organization implementation is preferable to affirmative action. In this speech, the negative will prove three things. One, that the affirmative proposal, the United States African Health Capacity Act, is insufficient to stop the HIV crisis in Africa and around the globe. Two, independent U.S. action will only disrupt international efforts directed at Africa and will disrupt internal African responses. And three, implementing the World Health Organization counterplan alone is the best policy prescription for stopping HIV in Africa and globally. Our first point is the affirmative proposal is just simply too small. Even assuming optimal conditions of training and implementation, the affirmative proposal will not stop HIV in Africa. Because of its regional approach, it will not stop the brain drain of community health workers from the African continent. The affirmative's primary author advocate, Laurie Garrett, senior fellow on the Council for Foreign Relations, admits that, and we quote, even if the affirmative's proposal, which is Senator Durbin's bill, is passed fully funded, there would still be a crisis. The African Health Capacity Act would only allocate $150 million a year over the next 3 years to train community health workers. This poses several problems for the affirmative advocacy. A, the affirmative is not topical. The affirmative maintains that a $150 a year increase in HIV expenditure is substantial, but according to Cates, the United States currently spends $4 billion a year on HIV assistance, and also PEPFAR was recently passed with a $50 billion budget. The affirmative proposal represents less than 5% or only 3.75% increase in funding for African health assistance. B, the parameters of this problem are too large to be impacted by the affirmative. There is a shortage of 1.5 million health workers in sub-Saharan Africa. According to Congresswoman Barbara Lee, sponsor of the House version of the bill, only 5,000 African nurses can be trained for every 100 million workers spent. Assuming that all 600 million allocated by the affirmative were spent on training community health workers, only 30,000 workers would be produced over 3 years to try to solve a 1.5 million deficit. The budget figures also prove the deficiency. The World Health Organization estimates that in 2008, the $8 billion would be required over the next 5 years to train and retain the minimum necessary number of healthcare workers. The affirmative would allocate less than $1 billion. And C, the affirmative causes brain drain because its efforts are localized to the African community. It does not address the global community health worker shortage, meaning that a majority of the CHWs trained under the affirmative will leave. Because the affirmative creates ties between the US doctors and the CHWs, those community health workers will probably train to the world's highest paying CHW employer, the United States. Our second point is that independent US action will cause several disadvantages. Passing the affirmative would A, trade off with other Department of State programs, B, PEPFAR's flawed policies, C, decrease international cooperation, specifically coordination with the European Union, and D, escalate a proxy war in Somalia. First is the A point. The affirmative would cause a budget trade-off. The AHCIA provides, and I quote, enacting the bill would not affect direct spending or revenues. Precisely because the money must come from Budget Function 150 for international affairs, the money for the AHCIA must come from other Department of State aid programs. By targeting sub-Saharan Africa, the affirmative forces the United States to cut off aid from the rest of the world, most likely to the Middle East and Northern Africa. George Curtis, who is the President and Chief Operating Officer of the Nuclear Threat Initiative, specifically warns against cutting humanitarian and medical assistance to this region because of historically tenuous relations. B, the affirmative policy would become PEPFAR Part 2. Both the affirmative and the negative agree that PEPFAR practices are wasteful and counterproductive. The affirmative argues that the AHCIA will be passed independent of PEPFAR. This is not true. The affirmative never refutes the fact that all US HIV assistance was consolidated into PEPFAR in 2003. There is also no available venue for the distribution of aid except through PEPFAR. Finally, the bill only allocates $150 million a year for doctor training. This is not enough money to establish a new implementing agency within the Department of State. Even if the affirmative avoids direct affiliation with PEPFAR, the AHCIA would be a direct clone of its predecessor. It would be PEPFAR Part 2 with the same bureaucracy, red tape, and ideological mission. The text of the actual bill mandates that the President appoints the program's director. So, President Bush will appoint Mark R. Dybul, the current director of PEPFAR and the Office of Global AIDS Coordinator, and an active faith-based supporter of the HIV programs to direct this program as well. The U.S. Leadership Against HIV/AIDS, Tuberculosis, and Malaria Act of 2003 created the Office of the Global AIDS Coordinator, which now oversees all HIV/AIDS programs. The Affirmative Plan and PEPFAR will be both under the control of the OGAC. Even if the affirmative is not conducted through PEPFAR, the director of PEPFAR will control the affirmative program. The affirmative has never addressed this issue during the course of the debate. The policies that the President implements under PEPFAR are intended to enrich his political supporters and favor U.S. faith-based initiatives. Faith-based doctors and nurses trained by the affirmative will only be able to prescribe U.S. drugs, and those doctors will emphasize PEPFAR's ABC model for abstinence, be faithful, and condoms for HIV prevention. This ABC model undermines the European Union, World Health Organization, and local policies. While international organizations encourage condom and antiretroviral use, the ABC model touts abstinence and faithfulness, often at the risk of middle-class groups. Helen Epstein, director of the Ford Foundation, argues that the ABC education associates condoms with sexual promiscuity. In her study, she noted that in Uganda, PEPFAR's policies actually increased HIV rates from 5% to 17% in the time that PEPFAR was there. And C, the affirmative policy would erode international cooperation. According to The Guardian, the EU and the World Health Organization don't like being undermined in their HIV policies and have repeatedly requested that PEPFAR policies end. They concede this, and they concede that the US needs European cooperation for NATO assistance in Iraq and Afghanistan. The affirmative would focus on sub-Saharan Africa to the exclusion of other nations. And our D point is the Somalian proxy war. The Eritrea-Ethiopia situation is a microcosm of the exclusion caused by such a policy. The U.S. will give aid to Ethiopia, which is a PEPFAR country, but will not give aid to Eritrea, a Muslim country. Ethiopia will perceive this signal as that its efforts in Somalia are tacitly condoned, and that the African-Christian war in Somalia against the Islamic Middle Eastern influence will continue. The AHCIA strongly suggests that nations affected by the program include PEPFAR-focused countries such as Ethiopia. Moreover, Ethiopia is the host of the only community health worker pilot program run by the United States presently. According to Marguerite Rowe, PhD and assistant professor of Columbia School of Public Health, Ethiopia will be a prime target for any CHW program because of its high rate of immigration of medical professionals. Therefore, there's no question that the affirmative will target Ethiopia or else risk topicality. Since 2006, Ethiopia and Eritrea have been waging a proxy war in Somalia. The United States has withdrawn its support of the Ethiopian military and has gone so far as to threaten sanctions should the fighting continue. Threats of sanctions are discouraging Ethiopia from continuing and escalating the proxy war in Somalia. The Affirmative Project, an overt gesture of goodwill towards Ethiopia, would undermine the current message and risk escalation of the war. Historically, conflict between Ethiopia and Eritrea has caused hundreds of thousands of deaths and catastrophic refugee flows. Moreover, the destabilization of the region would exacerbate disease spread and further alienate the international community. Our third major point is therefore that the World Health Organization counterplan is the best policy option. The Physicians for Human Rights, one of the affirmative's own authors, admits that WHO efforts to develop an international human resources database should receive the full support of the international community, and that wealthy World Health Organization member states should provide the World Health Organization the necessary financial support to carry out this and other World Health Organization activities. Therefore, the United States federal government should fund the 2008 World Health Organization Community Health Worker Proposal, as per the recommendations articulated at the International Conference on Task Shifting in Addis Ababa. The negative proposes that the U.S. exclusively shoulder the $8 billion cost. This will result in the training of more than 4 million health workers. The negative also proposes that all PEPFAR should be eliminated and all funding rerouted exclusively through the World Health Organization. The same CHWs will be educated by the World Health Organization, and the workers will be trained in all countries affected by HIV/AIDS. These community health workers will emphasize a safe sex approach to HIV prevention rather than the ABC model. The World Health Organization would also provide all the necessary infrastructure required for this proposal. The Addis Ababa conference indicated this point exactly. The affirmative has never offered nor suggested a combination of both policies. Therefore, the negative counterproposal implemented alone avoids disadvantages that simultaneous action would incur. The EU has gone so far as to publicly condemn the U.S. public health assistance for instituting confusing practices, buying only certain drugs to protect pharmaceutical companies, and foregoing some effective prevention tools like condoms for political reasons. Working with the World Health Organization would eliminate what Stephen Lewis, the UN Secretary General's special envoy for HIV/AIDS in Africa, calls a serious obstacle to global efforts to combat HIV/AIDS. Lewis also goes to praise WHO for its effectiveness. In conclusion, we have provided 3 major reasons to support the negative. Thank you. Thank you very much.
Captains, thank you. We will now start with begin the cross-examination period. First, between the two teams, we will begin with a question from the affirmative to the negative.
In the African Health Capacity Investment Act, it specifies that a major problem in the status quo is not only the lack of community health workers, but it is a lack of doctors, nurses, and other medical staff as well as a lack of health clinics. Through the counterproposal, you aim to solely increase the amount of community healthcare workers throughout the world. How will these community healthcare workers be able to live up to qualified medical staff and be able to work in conditions that are unsanitary and do not have the adequate amount of clinics or management that is needed to solve?
Andrew?
Our counterproposal through the WHO would provide for doctors and nurses as well as community health workers. When we suggest training health workers, we mean just that, doctors, nurses, paraprofessionals, and other health workers. Community health workers are a subset of a larger group of health workers. The WHO proposal from which we draw our counterplan clearly outlines that we would provide $8 billion for all health workers. And may I note, our $8 billion would actually provide more of the doctors and nurses that the affirmative is citing than the affirmative's total of $600 million, meaning that our counterproposal would provide for exactly the doctors and nurses that they say are necessary to combat the AIDS crisis in Africa.
A question from the negative directed to the affirmative.
Kahuku. A majority of the authors you cite saying the WHO is bad ultimately conclude that the WHO is in fact the best actor. Specifically, the Physicians for Human Rights, your source, says, and I quote, WHO efforts to develop an international human resources database should receive the full support of the international community. The report additionally states that the WHO should develop and disseminate good practices in health sector human resources planning and management. Wealthy WHO member states should provide the WHO the necessary financial support to carry out this and other WHO activities that are part of the organization's promotion of human resources and health systems development. Bates additionally says, quote, part of the WHO's problem with setting targets like 3x5 is that it does not control enough funding to substantially increase treatment. Much of the funding is managed by purpose-designed organizations such as the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR. Given that the authors you cite in your rebuttal actually endorse the WHO counterplan, wouldn't you agree that the WHO implementation is the best policy prescription? If not, do you have any other authors or evidence available to substantiate your position?
Anna, Rebecca, or Nick?
To address a negative question, first off, when you actually listen to the first line of the quote, it says that we should support World Health Organization's human resource database. My first question to this is, what exactly is their human resource database? A database to me doesn't sound necessarily like a plan that we are trying to implement with lots of doctors, nurses. A database to me sounds like some sort of system. So first I'd like to clarify or point that out. Secondly, it doesn't say that the World Health Organization would be better than the United States at implementing such a plan. It just states that we should support such efforts. So when you look at this, you can see that this evidence that they brought up from one of our affirmative authors, which they don't specify, is not necessarily as strong as they make it out to be. Secondly, we know that our plan is better than the World Health Organization because the World Health Organization has been known to only cater to wealthier nations, which, as we know, wealthier nations are not sub-Saharan Africa, and if they only cater to these nations, obviously they're filled with bureaucracy and they wouldn't be implementing a good plan for sub-Saharan Africa.
A question from the affirmative, either Nick or Rebecca, to the negative.
Okay, my question is, well, PEPFAR has been around for over 4 years and has been instrumental in combating the HIV/AIDS epidemic in sub-Saharan Africa and helping millions of people. And PEPFAR has administered life-saving antiretrovirals to millions throughout Africa and has also taken steps to educate the African people through venues such as the ABC policy. And in your plan, you state that you will be redirecting current PEPFAR activities to U.S. aid. How will the U.S. aid, which is a part of the U.S. federal government and still subject to Bush's ideological policies, use this money differently than PEPFAR, which you so heavily condemn?
Jenny or Satish?
Actually, PEPFAR, despite all your claims that it's laudable and it's a great organization, that's not true. AIDS rates have gone up in sub-Saharan Africa over the last 4 years. specifically, you can look at the case of Uganda. Before PEPFAR was implemented, the AIDS rate was around 6%. 4 years from then, after PEPFAR has been in place for 4 years, the AIDS rates have skyrocketed to 17%. So PEPFAR is not as great as you say it is. Specifically on the issue of ARVs, or antiretrovirals, PEPFAR uses ARVs that are manufactured specifically by American corporations that cost 6 to 8 times the going world rate for ARVs. The EU, India, other places make ARVs much cheaper and just as effective, and the World Health Organization specifically endorses those ARVs which PEPFAR does not use, and that's made the EU and India and the entire international community very irate. On the issue of ABCs, this has specifically been multiple professionals, specifically Dr. Halpern and Epstein, which we cite in our papers, have spoken against ABCs, that these actually increase the spread of HIV within sub-Saharan Africa, that they're not, it's not an...
Thank you. A question from Jenny for Nick.
Team Kahuku, you assert in your paper that you would prefer your program be implemented through some agency other than PEPFAR, but you do not change the rules that make the Office of the Global AIDS Coordinator responsible for implementing your proposal. Furthermore, you do not increase funding as specified by the Durban Bill for your program, which remains static at $150 million a year. And our first subpoint is, if your program is implemented despite rules to the contrary through some other agency within the U.S. Agency for International Development, could you please specify what agency? And secondly, if you create a new agency, how much of the only $150 million a year that was originally intended to go towards community health worker training are you willing to sacrifice for the formation of this new bureaucracy? Thank you.
Nick?
We're not actually creating a new agency to administer these programs, but we're not doing it through PEPFAR, and we're not using any of the ABC model or any of the ideological proposals that George Bush has done through PEPFAR. What the ABC policy is specific to education and saying that they're going to train Africans to abstain, be faithful, or use condoms. What our plan is doing is improving the infrastructure and providing retention for health workers. So this has nothing to do with the ABC policy. What was there another part of the question? What was the other part of the question?
Sure.
The second part of my question, well, I guess you already answered that. So our first question was, if your program is implemented despite rules to the contrary through some other agency within the U.S. Agency for International Development, could you please specify what agency? Thank you.
Well, I already specified that we're not actually setting up a new agency to administer it.
Okay, thank you very much. And again, would like to extend a warm welcome to our panel of judges. We will now begin the question and answer period from our guest panel. Captains, again, your assistance in making sure that we are directing answers across and around. No, that's there were two questions, two answers, two answers. Right. All right, go ahead.
Thank you. Those are great presentations. My first question is directed to the affirmative, and its topicality. It's the issue of the resolutions calling for a substantial increase. You heard the negative talk about a 5% increase, which I assume they calculated somehow, without the benefit of my calculator, to be $150 million each of 4 years, as compared to the current $50 billion per year, as I understand it. Is your proposal substantially, is 5% substantial?
Okay, well, the negative assumes that substantial aid has to be just money aid and it has to be compared to all of the HIV's AIDS assistance given in the status quo. But when you look to the resolution, you have to look at how much money is being given towards infrastructure and healthcare workers from the United States right now. And as of now, the United States is spending $0 on this. So by increasing it to $600 million, we will be able to provide a substantial increase in HIV AIDS assistance to sub-Saharan Africa. Also, we coordinate with international donors and international organizations that will also be able to provide aid to sub-Saharan Africa as well. And, do you want to ask?
Yeah, does the resolution, is it worded to just infrastructure?
No, but the specific HIV/AIDS assistance that we are giving is infrastructure and healthcare workers. So in the context of the amount of healthcare workers that are in sub-Saharan Africa and the amount of infrastructure that is in sub-Saharan Africa, the amount of aid we're giving is a substantial amount.
I understand that's what your proposal is, but is the resolution directed as narrow as your proposal?
The resolution doesn't specify infrastructure.
It doesn't?
No,
Okay.
it doesn't.
Other questions? Mr. Baker? Or no, I'm sorry. Mr. McGrath?
This is directed to the negative. Your counter proposal is for, I think it was $8 billion with regard to training and personnel. Do you agree that infrastructure is necessary for these new personnel to be effective?
Thank you for that question. And yes, we do agree that infrastructure is necessary. And we stated very explicitly that the Addis Ababa conference, where the outlines for this WHO counterplan basically were developed, do state that infrastructure will be provided for training community health workers. And additionally, we'd like to note that the $8 billion is far more than any amount the affirmative could provide. So ultimately, we would provide more infrastructure so that we don't come up with this problem where we may have infrastructure but far too few workers, or vice versa. Thank you.
Just to clarify, I meant infrastructure not in the training, but infrastructure in the actually distribution of services and aid. Are you saying your $8 billion is going to be dog-eared for infrastructure like building clinics and getting medicines to and from points of access?
Yes, we do agree with that point. So when we train the community health workers through the World Health Organization, we're not only just training them, we're also calculating the cost of building their clinics, providing them with supplies. So we're not just educating them and leaving them out in the cold. We're following through with that and also providing all necessary logistical support for them.
Thank you.
One more follow-up? Sorry. So what then is the difference between your counter proposal and the affirmative other than the amount of money that you're talking about?
There are several differences. First of all is the amount of money. Also, secondly, because we impact a much larger region, so we're not excluding other areas that HIV does not affect. And thirdly, because our counterplan will additionally ban PEPFAR and go entirely through the international arena, which will increase international cooperation. And fourthly, because when we go through the international arena, we're not going to be subject to the policies of PEPFAR, which often stress earmarks and restrictions on the type of aid. So we're going to be more complicit to international policy rather than unilateral U.S. policy.
Will?
Question for the negative. The moderator may decide that the affirmative should get a chance to respond. It's just a evidentiary clarification that I would like. The affirmative has suggested that you all don't actually have a specific author that compares WHO versus the U.S. in terms of agent effectiveness related to this question. Can you point to one of your authors that specifically says that WHO would be better to do the proposal rather than having the U.S. do it?
Yeah, we have a couple of authors, actually, Mr. Baker. First off is Stephen Lewis, who's the special envoy from the UN regarding HIV and AIDS. And he specifically compares PEPFAR to the WHO and concludes that the WHO is much better than PEPFAR. Additionally, the claims that we're making that affirmative authors say that the WHO is better are coming from Mr. Amir Attaran, who's he specifically addresses the issue of ARVs and drugs that both PEPFAR and the WHO use. And Mr. Attaran specifically says that the WHO is able to use more drugs. Additionally, Roger Bates, another affirmative author, specifically notes that the WHO, given that they weren't inhibited by PEPFAR, basically PEPFAR puts earmarks on how the WHO can use money that's given to it. If that didn't happen, the WHO would be much better at doing what it tries to do.
I think it is fair to extend that question to the affirmative.
What the point that we're trying to point out is that while they may have affirmative authors that talk about the World Health Organization and PEPFAR, our plan is outside the scope of PEPFAR, and they fail to bring up evidence that saying the U.S. itself would be bad at providing this kind of efforts, or that the World Health Organization would be better. By merely comparing PEPFAR efforts, which is outside the realm of what we the FIRM team have advocated to talk about today, is still not providing any evidentiary support of their arguments.
Okay, other questions? Yes, sir.
For the affirmative, do you have an agency that you are going to substitute for PEPFAR? That question seems to be dodged earlier. Is there, you say it's not PEPFAR, but you also say that the U.S. could be good at implementing your policies. Well, what agency?
Nick or Rebecca?
Okay, well, we're not setting up a separate agency itself. It's going to be funded through the same agencies that are overseeing AIDS funding as it is, but that's not necessarily, not all AIDS funding is going through PEPFAR specifically. Is that?
Can I add to that?
Sure.
Well, also, under our act, the president is required to create a strategy that would involve many agencies within the United States federal government, and none of those, the bill does not specify that they will be related to PEPFAR. It's just agencies such as USAID and those types of agencies. And also, the bill also specifies that the president needs to create a strategy that would coordinate with international donors and international organizations, such as the European Union and also the World Health Organization.
Thank you. Additional questions?
I don't know who to address this to, but I'm a little concerned by a counterproposal that says do away with PEPFAR, and we have an affirmative team that doesn't use PEPFAR, and then we have, a WHO program to train health workers, and we have an affirmative program to train health workers. Given the magnitude of the problem, why don't we just have two programs that train health workers? And how the heck is this PEPFAR thing a reason to vote against them? I guess I'm asking the negative.
Okay, Jenny, we're going to ask you to set this one. I need the other three.
Thank you for the question, Mr. Snyder. Our evidence indicates that the Office of the Global AIDS Coordinator, which was established in the same act that established PEPFAR, put all AIDS assistance coming from the United States under the control of the office. The current director's name is Mark R. Dybel, and not only does he serve as the director of this Office of the Global AIDS Coordinator, but he is the director of PEPFAR. Now, Mr. Dybel historically has been a proponent of the ABC approach as well as faith-based organizations, which is essentially what President Bush put him in there to do. So his control extends, seeing as the affirmative just conceded that they go under the agency that deals with AIDS assistance. His ability to control the plan would be placed under him, meaning his same proponents of the faith-based organizations as well as the ABC approach and these conservative Christian agendas would be placed on the affirmative as well. Additionally, the banning of PEPFAR would remove all funding and the ability of Mr. Dybel to control the plan or this training of CHWs and place it under the WHO. That's the differentiation.
Thank you. Yes?
The money is second. So PEPFAR is disbanded, according to your counterproposal. Is that right?
PEPFAR, all the money that's currently allocated to PEPFAR, well, first of all, it's not $50 billion per year. It's $50 billion. The Congress bill that did that says $50 billion over 10 years, or about $5 billion per year. We would have the money that would be allocated towards PEPFAR be diverted to the WHO in the form of like a block grant.
Okay, so then it's $5 billion a year to the WHO. Is that right? World Health Organization?
It's $8 billion to the WHO. We also use other monies that are under the Office of the Global AIDS Coordinator but aren't specifically allocated to PEPFAR.
$8 billion per year?
$8 billion per year would go to the WHO, specifically for the training and employment of health workers.
And that's U.S. money?
That's our money that goes to the WHO.
So is that the net increase of $5 billion to $8 billion? So $3 billion more? Is that?
Right.
Is that the way it works? Okay, good. Just wanted to...
A follow-up for the negative. How is that a negative to the topic, which is resolved the United States federal government should substantially increase its AIDS, HIV, public health assistance to sub-Saharan Africa? Aren't you effectively, in your counterproposal, seeking that substantial increase but directing it through a different organization?
We would point out that's a great question, Mr. McGrath, and that's a legitimate concern. We point out a couple of reasons why this would be a reason to negate U.S. action. First of all, all of our points prove that U.S. unilateral action through its only actor of AIDS relief, PEPFAR, is a detrimental thing, and it actually hurts the situation. And we say that international actors need to be empowered to undergo HIV/AIDS assistance, meaning that we, instead of advocating the United States to substantially increase its assistance, we think the World Health Organization substantially increase its assistance. And as U.S. policymakers, we should support that, and that's our advocacy. So we should fund that the WHO should do this public health assistance program globally.
So then the money it's the U.S. government increasing the assistance, the dollars, to the sub-Sahara through the WHO. Is that the way it's working?
It's not an increase so much as a redirection of money. Like, we're not allocating any more to AIDS assistance per se. We're taking all the money that's currently used by the United States, and that would amount to about $8 billion per year, and have that go to the WHO instead.
On the end.
Could the affirmative try to address some of the criticism of the PEPFAR program? I know you're saying you're not using it, but and that your program is setting up the infrastructure, but it also doesn't say how that infrastructure is going to be useful if PEPFAR is still the main source of work to actually address the health concerns there. How do you get around that?
Okay, so what the affirmative team is our position is that PEPFAR is not a bad thing, that it actually has done good for sub-Saharan Africa. As I read in my first constructive speech, that it's helped millions of people with their AIDS and HIV crisis in sub-Saharan Africa, and that according to Medical News Today, the biggest problem with PEPFAR right now is its lack of health worker sustainability and clinics in the area. And even the World Health Organization has said that this is the major problem. And so by passing the affirmative plan, we'll be setting up these manageable health systems that we can then use all of these other international actors, money, ARVs, the treatment that they're trying to use now, we'll be able to use it more efficiently. So the PEPFAR is doing well right now, but it will work even more efficiently, and we'll be able to utilize our billions of dollars even better by passing this plan. I don't know if that addresses your question, or if you can re-clarify.
Would you like to address that to someone else, or is a follow-up? Okay. Yes.
Okay.
I bet the affirmative, they claim that your proposal is going to be administered by Mr. ABC Faith-Based Initiatives. Is that true?
This is not true. They don't specify any source that connects this. There's no link to our case. They just assume that since that most of the money that is going from the United States government to sub-Saharan Africa is through PEPFAR, that our plan would be the same. However, the bill does not specify that this Mark, whatever his name is, the director of PEPFAR would be, in fact, the person in charge. In fact, it specifies the person in charge would be the president at the time, and he will create a strategy that will go through Congress, and Congress will approve of this strategy, and it would effectively address the problems that we now face in sub-Saharan Africa concerning healthcare infrastructure and also the health workforce crisis.
Yes.
So basically, it's the president, it's Bush or it's somebody else that's going to control how the money's spent. So,
yes.
Right. Okay.
Yes,
so,
the
how do you
president with the advice and consent of Congress.
Of
yes.
course. Oh, okay. So, how do you respond then to the criticisms that the negative raised about faith-based programs that don't recognize the many hundred-year cultures of African nations that don't really respond to necessarily U.S. faith-based programs, for example, on contraceptive use, etc.?
Okay, well, the negative assumes that we will just be using PEPFAR and that we'll be using all the practices that they have. But right now, what we're doing through our plan is actually improving the infrastructure and improving the clinics and the sanitary conditions, which in no way is faith-based or depends upon the ABC policy. So it's completely separate from what PEPFAR is doing in the status quo. And also, what we're doing, health workers aren't necessarily faith-based either. They're going to be able to provide for all of the population of sub-Saharan Africa, not just what President Bush is doing in the status quo. That's why we need to pass the African Health Capacity Investment Act to add on to PEPFAR so we can sustain more of the population and get access, so people can get access to these clinics and this health infrastructure.
Can I also add to that? And also, if you look in the negative construction, I'm quoting from their case, they say that they counter-propose that all PEPFAR, United States leadership against HIV/AIDS, etc., activities be redirected through U.S. aid. So themselves, they're still redirecting these activities through the United States federal government. So they themselves do not overcome these ideological policies if you were to accept that their attack on that.
That's time. Question?
Do a follow-up on that?
Sure, of course.
Just a quick one. That is, so cleaner clinics, more money for infrastructure, but if the ultimate strategy doesn't change because the president, whoever's elected, has the same ideological bent as the last president, how does your plan really get well received by a different culture with different values on monogamy, et cetera?
Nick?
Could you repeat the question? I'm sorry.
Is it workable to expect that even with better clinics, if you're sitting in a better clinic and you're simply saying to people, do it my way, it's abstinence, contraceptives are not an option, is it really practical to assume that thousands of years of culture are going to change overnight?
Okay, well, the main problem with HIV/AIDS is essentially the culture that they have these polygamist ideals and that they're not actually using the contraceptives and things. So if we were going to completely reroute all funding from any type of education to try to break down these cultural barriers, then that would allow AIDS to rise again, to continue to rise exponentially, because of course there is no cure for AIDS. What we're doing is not actually going in and sending the U.S. in to take over their medical infrastructure. What we're doing is we're funding the infrastructure that exists and we're helping to improve that, and that will help to expand what already exists and get them better quality health care.
And if I could add on to that, just a quick thing, is that we're enabling Africans themselves to run these systems so that they know the cultural practices, they know what barriers there are, and they can relate to the people the best. And so many of these cultural barriers can be overcome when we actually enable Africans themselves to get involved.
Thank you. Panel? Yes.
This is to the affirmative. If the plan is to build clinics to train health workers, is $600 million enough? Is $150 million over 4 years enough to be effective? I mean, it seems like it is a drop in the bucket.
Well, what we're proposing, the majority of it is not extremely expensive. For example, we've brought up evidence showing that many clinics do not have running water or electricity, or they're not very cleanly, and this is helping to spread infectious diseases. And these things aren't incredibly expensive to solve, but when we do solve them, they have an incredibly huge impact on the quality of the health care.
What's the source of that, that assessment? Because, I mean, given there's hundreds of millions of people in Africa, 150 million just doesn't sound like much. It's $1 a person or something like that.
My team is looking for that specific source. Another reason why our plan is workable, even though it's not an exorbitant amount of money compared to the negative team, what we do is we coordinate with international organizations, and so they're also, all of their money can be utilized to do these simple things. And we're building off of existing infrastructure. So as my partner said, it doesn't have to be extremely expensive. And we're not only training workers, a large part of it is retaining. And so retaining doctors isn't expensive. You just have to set up the systems, and they themselves would stay, as our studies indicate.
Yeah, the source for that specific example was Laurie Garrett, as we had brought up earlier.
Next question. Will?
A question for the negative. This is just kind of clarifying the strategic elements. As the firm has talked more about their policy, apparently they're going to also engage international donors and international organizations, including, for example, who are obviously there are differences in dollar amount between the affirmative and negative. Are there also ultimately differences in strategy, and if so, what are the critical ones?
And
sorry, there we go.
Andrew or VJ would be my preference.
Certainly.
Just to get this evened up.
When they enact their policy, they've already conceded that they would have the same funding mechanisms as are currently used. And Mr. Mark Dunna, he's not just the head of PEPFAR, he's the head of the... Oh, I'm sorry. Dibble. I'm sorry, Mr. Dunna. We are aware you're not the director.
I'm flattered, though.
So Mr. Mark Dibble is not just the director of PEPFAR, he's the director of the Office of the Global AIDS Coordinator, meaning he coordinates all U.S. aid that goes to AIDS relief. It means they would be under his jurisdiction, meaning that he could use these aid to continue current policies, which are unilateralist, offend the EU, would cause a proxy war in Somalia with Ethiopia, and continue this ABC policy, like Mr. Dunna said, is very culturally insensitive and has been proven ineffective in places like Uganda. So this means that their policy would be detrimental and it would be politically charged as opposed to a apolitical policy.
Questions? Okay. Yes.
For the negative, does your counterproposal address the brain drain, and how is the WHO's involvement going to be any different from a point of view of people getting training and then leaving, which I believe is your criticism of the affirmative, but it may be your counterproposal is susceptible to the same thing.
EJ?
Thank you, Mr. McGrath, for the question. We have several ways that the WHO will be able to stop this problem. First is the increased training in places that experience large amounts of emigration. For example, Ethiopia was where a pilot program for community health workers took place. We will target these areas and increase the number of people working there. Additionally, through this $8 billion budget, allocate some of that to increase the pay for doctors and workers in the areas to keep them there, because that's really why they're moving away, where in places like Uganda they make $1,000, $1,700 a year. If they move to the United States, they can make upwards of $10,000, $20,000, $30,000. So increasing the pay will stop the emigration of these workers and be able to stop the regional shifting to areas where the pay is higher. By kind of evening out the pay balance or the pay scale in different areas, we will be able to successfully stop the regional shifting within sub-Saharan Africa. If that answers your question.
You have 8 seconds-ish, yeah?
And we address the pull factors as well through a global solution to the World Health Organization. That good?
That's good. That's way good. 2 seconds to spare. Any other questions from the panel? Yes.
When you say that you will be doing that, is there a concern that once this money goes to the WHO can do whatever it wants with that money? I mean, at that point, the U.S. is kind of out of the picture. Is that correct?
Actually, the WHO's already made this proposal. They've already had a conference in the capital of Ethiopia, Addis Ababa, and they've outlined exactly what they want to do, and they're starting to ask people to contribute to this initiative for community health workers. And our counter proposal would just have the United States pay that specific amount, like pay for that. So it wouldn't, there's no concerns about it being redirected places.
Yes, ma'am.
I was wondering if the affirmative has a response to the unilateral criticism with the EU not supporting the policies that we're currently implementing and that impact on the way that the U.S. is viewed by the world.
Yes. Well, according to the bill, the African Health Capacity Investment Act, there is a part of the bill that specifies that the strategy that the president is required to create, there's a part of that strategy needs to involve international cooperation. And it states specific organizations which the president needs to create involvement with. And some of those are the European Union and also the World Health Organization and other organizations such as the African Union and the World Bank and those kinds of international organizations and also other countries. And so this will not be a unilateral project. It will in fact be a unilateral project, and so therefore the negatives attack is illegitimate.
Yes.
This is a question for both. Brain drain, the immigration issue it's come up in a number of different ways. How will, first for the affirmative, how will your plan with limited $150 million in infrastructure have sufficient money to somehow, I think you said earlier, increase, Anna, you said increase salaries and benefits of thousands and thousands of workers, and then on the negative as to your counter plan, what is your plan on avoiding the immigration?
We're getting toward the end. I'd probably like to direct us to even it up a little bit, to either Sarah or Anna. One of you take that.
Okay, well, if you
Thanks.
look to our constructive speech, it specifies that a study done by the Global AIDS Alliance talks about how if the African Health Capacity Investment Act were to be passed, it would retain over 20,000 doctors and nurses and medical professionals each year. So slowly by passing the act, we will be able to retain these specialists and slowly decrease the brain drain that is happening in the status quo.
We also have regional, the act specifies one of the provisions it wants to do is to help with the regional disparities in sub-Saharan Africa. So if pay is more inadequate in an area, more assistance would go to that region. And again, as we specified earlier, that a lot of the problems are simple problems, but they're making a big impact. So like if management isn't very expensive. You know, you can send workers in there and clean up the system, make them more efficient, and that will have a large impact. And so it doesn't necessarily cost millions of dollars like the negative team is proposing, that we give $8 billion to fund this plan.
Do you have support for the argument that there's enough money to somehow bring some parity between the kinds of economic rewards one a worker gets in Europe or United States as compared to what you can do to increase? What would you have to do?
Well,
increase the numbers by hundreds or thousands?
Okay, so we don't have specific numbers of how much like we need to increase by X amount, but what we do when you think about it, there are several studies that show that if they could make a living wage in sub-Saharan Africa and be doctors, and if there were more opportunities, that local doctors would prefer to stay in their homeland. They want to be able to help if they could just receive a living. And we don't have to make as much as an American doctor or Western doctors. It's not necessarily only the salary that's pulling them, because if you can compare the cost of living in each area, you can live very comfortably being a very rich man or woman in sub-Saharan Africa, and if there's a difference. Even if you're being paid less, you can still live very comfortably.
Also, the main reason why people are leaving sub-Saharan Africa is because of the poor health infrastructure there and because of the lack of educational opportunities, which our bill is directly trying to solve, rather than just paying money to train new health workers as the negative has proposed.
We'll need to direct the last few questions to the negative, please. Questions for the negative. Yes, Dr. Schneider.
All right, let's try this again. For the way I see it is that the reason I want to do the counter plan is because it's going to escape Mr. ABC faith-based initiatives, and they're not. Now, they claim he's not going to be in charge. Now, there's I understand that everything to do with AIDS was centralized under this one. Yeah, but they're the affirmative. They're proposing change. Why can't they do that? And it seems to me that that's the only thing that's making the counter plan a reasonable alternative. Convince me otherwise.
Okay, thank you, Mr. Schneider. First of all, the affirmative will pass Senator Durbin's bill as it is, which means no revisions. And we have the actual text of the AHCIA, and where the text says that the president will appoint the director. So and they have also conceded several times for this debate that they're going to send it through the primary agency of U.S. HIV assistance in the status quo. Given those two concessions, first of all, the first concession, act itself proves that the president will appoint the director, and because the same act that created PEPFAR, created the OJAC, there's no reason why he would not appoint the director, and even if it is not Mark Daibu, it will be a very like-minded person like him. And secondly, the concession that it will go through the same agency that PEPFAR goes through means that even if they don't work with or through PEPFAR, their agency will effectively implement the same ideological restrictions, making them a PEPFAR Part 2. So even if, we criticize PEPFAR not because it's PEPFAR, but because PEPFAR's policies, the ABCs, the earmarks, the restrictions are flawed. So they're essentially going to create the same thing. I hope that helped.
Yes.
To follow up on that, didn't the recent congressional increase in PEPFAR's funding also remove the abstinence requirement? So doesn't that undermine your argument?
Either one of you. Yeah, Andrew or BJ.
That's a great concern, Mr. McGrath. May I also note that same piece of legislation also now contains more references to the ABC model than did the previous legislation, meaning that it actually increases the PEPFAR's commitment and the OGAC's commitment to abstinence only in these faith-based initiatives. And it's been supported in the literature. Some Democratic senators have come out and said that this is in fact a more abstinence-focused initiative now than it ever has been before. Additionally, the president will institute policies that he wants to institute, and that's just obviously what he's going to do. The Act concedes all implementation to him, meaning he's going to appoint a director that does what he wants. He will do what he wants with the program because he's in control of it, and that means that regardless of whatever legislation Congress puts on him, he's going to make his own faith-based restrictions on how the aid is administered, and it'll be very abstinence heavy and very faith-based heavy, and that's what's going to happen.
We have time for one more question. The question needs to be directed to the negative and specifically to VJ. Do you have a question for VJ?
Sure. VJ and I haven't had enough time to talk yet today. I want to follow up on that question, specifically about the, I need you to go a little bit deeper into the analysis of why when you remove an ABC requirement, which the Act specifically does, even if there are more references, how that means that there will absolutely be more abstinence-only education things going on. I get the notion that the President prefers it. I get the understanding of that, but it's no longer an absolute requirement in the current piece of legislation that was required.
Right, Mr. Baker, I understand your concerns. It's not in the text of the law itself anymore. The earmark has been removed. However, Mr. Dybel has gone out publicly and expressed his support of these ABC models as well as the faith-based initiatives, and all PEPFAR activities are under his direct control, being the director of the Office of the Global AIDS Coordinator. Means even if it's not on the books, his preference still lies with the conservative path and these faith-based organizations. There hasn't been any evidence to the contrary. There is no evidence of PEPFAR doing anything but these ABC methods and choosing the brand name ARVs that the U.S. companies make. The corporate cronyism and conservatism exhibited by PEPFAR have been especially compounded since 2006 when Mr. Dybel was put into the office. So all continued action under his control will follow this path into more conservatism, and there hasn't been any substantiation of claims to the contrary. So going on empirical evidence, we'll have to err on the side of caution and say that these conservative values will continue.
Thank you very much.
Only for a couple of months, though, right?
Mr. Dybel will outlast President Bush, so it could continue indefinitely.
Thank you for your good questions, and we appreciate your participation in the debate. We will conclude the debate with rebuttal statements, starting with the negative for a period of 5 minutes.
The question for today's debate is simple: whether or not we want a piecemeal regional solution or an international effort. The affirmative would have the United States administer a program to increase the number of health workers in sub-Saharan Africa, while the negative would have the World Health Organization administer a worldwide program to train and employ health professionals. The World Health Organization would address HIV across the globe, including South and Southeast Asia, Central and South America, Russia, and East Asia, all of the places that the affirmative would not address and the significant places that these health workers are emigrating to. We address the demand side as well as the supply side of this crisis. The debate has come down to 3 main issues. The first is that the World Health Organization is better suited for community health worker programs and thus preferable to the United States. 2, that a U.S. administered program would suffer from the same problems as PEPFAR. And 3, that the international community has already voiced its concerns with PEPFAR and these problems, with PEPFAR and the ABC method. First, the World Health Organization is the ideal venue for a CHW program. The World Health Organization would address the entire globe and the worldwide shortage for 4 million health workers. Because the WHO is internationally recognized and apolitical, the WHO would be better received than the politically charged U.S. PEPFAR and similar programs. Furthermore, the WHO would be better able to train health professionals because the WHO chooses education styles, prevention efforts, and medicines based on their efficacy, not on a political agenda. Roger Bates and Amir Taran, both affirmative authors, actually conclude that the WHO would be the best organization for a CHW program. The Physicians for Human Rights, the affirmative's favorite site, goes so far as to actually propose the counter-proposal, and I quote, WHO efforts to develop an international human resources database should receive the full support of the international community. Wealthy WHO member states should provide the WHO the necessary financial support to carry out this and other WHO activities. It's come up that the human resources database may not mean the exact same thing as the counterproposal, but the context of the quote is the exact same thing. That's what he's talking about, specifically to address Mr. Snyder's concern that you could do both. First of all, the affirmative has never suggested this combination of proposals, and secondly, the Act only allows consultation. It doesn't allow a joint initiative between the WHO and the African Health Capacity Investment Act. Furthermore, even if both happen, it would still leave PEPFAR in place, which hurts the World Health Organization, and it would still allow faith-based groups to influence the program. For instance, Mark Dybul might now be the joint coordinator of the WHO and U.S. proposal. Going on, all United States HIV assistance is coordinated by the Office of Global AIDS Coordinator. Mark R. Dybul, who holds this office, would control the implementation of the African Health Capacity Investment Act. Dr. Dybul, who has repeatedly voiced his support for faith-based initiatives and abstinence-only education programs, or he has done that. Furthermore, the African Health Capacity Investment Act stipulates, and the affirmative concedes, that the President would control the operations of any CHW program and that the program must work with PEPFAR-focused countries. We can logically conclude that if the same people are organizing and operating the CHW program, it will operate similar to PEPFAR. Stephen Lewis, the UN Special Envoy regarding HIV and AIDS, has heavily criticized PEPFAR and suggested that all funding be redirected to the WHO. Though the African Health Capacity Investment Act may consult other peoples, we've already heard their opinion. The EU and other member states of the WHO have all repeatedly voiced their dissent with the United States aid because it restricts condom usage specifically and because it only uses American-made ARVs, which cost 6 to 8 times more than other antiretroviral drugs. The current operating procedure for United States aid is wasteful, inefficient, and ineffective. The World Health Organization, being an apolitical entity, carries no political message in its assistance. This is not true of the United States. The AHCIA would target Ethiopia for numerous reasons. First off is that Ethiopia was the site of the original pilot program for the CHWs. 2 is that Addis Ababa has been host to multiple CHW initiatives. And 3 is that Ethiopia is a high priority for PEPFAR. When the United States gives aid to Ethiopia directly, that's going to be perceived by Ethiopia as a green light, i.e. a signal from the United States to go on with its initiative in Somalia, and that's going to be bad for the reasons cited in the affirmative constructive, or in the negative constructive and rebuttal. The affirmative's regional and inadequate solution will not address the 1.5 million worker shortage. It will also hurt EU and Middle East relations and will be emblematic of the United States PEPFAR. The World Health Organization offers a comprehensive and globally orchestrated solution that would address the worldwide shortage of healthcare workers. We urge a negative ballot and endorsement of the World Health Organization.
Thank you. The final rebuttal statement for the affirmative team.
Today's debate will come down to which policy option should be preferred and which policy option will be able to alleviate the HIV/AIDS crisis that is happening in the status quo and will be able to provide for the best sustainable and long-term solution to the people of sub-Saharan Africa. When you look to the negative counterproposal and the affirmative case will always be superior for the following reasons. The first reason is under healthcare workers. The original negative constructive speech specified that their counterproposal would only provide for community healthcare workers without providing sub-Saharan Africa for health professionals, doctors, nurses, or other medical staff. The community healthcare workers alone will not solve. We provided evidence on how key these health professionals are in the status quo. Also, the affirmative will retain 20,000 health professionals each year, whereas the negative just trains 4 million community healthcare workers. They do not retain doctors or nurses, but they just merely hire them. Next, the affirmative plan will be able to achieve what the negative does, because not only do we train community healthcare workers, but we provide for these doctors and nurses and provide for this medical staff that are effective in fighting the HIV/AIDS crisis. Moving down to the second reason is infrastructure. The negative now claims that they will be able to provide infrastructure for the people of sub-Saharan Africa. However, if you look to their negative constructive paper, it specifies that they are just providing community healthcare workers. And also, if you reference the negative rebuttal, it talks about who is good for a community health worker program, not for infrastructure and not for medical professionals. So clearly they are not addressing the lack of infrastructure in the status quo. And we have proven to you how effective infrastructure is. In Haiti, there was an example given how right now in Haiti, by increasing the incentives and the wages, they were able to increase the retention rate of doctors and nurses in Haiti. And also, the other example we gave was under Josh Ruxin, who was able to increase the amount of patients that they are able to treat each day. So by improving the infrastructure, by improving the clinics and the amount of sanitary conditions and incentives and wages we do, we will be able to increase the amount of people that we will be able to reach throughout sub-Saharan Africa and decrease the HIV/AIDS crisis within the region. Moving down to the next reason, the negative team talks about PEPFAR and how we will not be able to solve because PEPFAR is an inadequate program. However, if you look to the negative counterproposal, they plan to reroute their funding through the United States and give it to the World Health Organization. There's no reason that this funding will actually change the ideological policies of the Bush administration or of PEPFAR itself. So the negative team would fall to these same ideological principles as PEPFAR in the status quo. Next, the affirmative plan is not doing what PEPFAR is doing. We're providing infrastructure, we're providing clinics and retention of doctors and nurses. This is in no way faith-based assistance to sub-Saharan Africa, so clearly we are outside the scope of PEPFAR. Also, we will be overcoming the problems that PEPFAR has in the status quo. My partners have read quotes talking about how in the status quo, PEPFAR's problem is the fact that they don't have adequate infrastructure. And by providing this infrastructure that is key to solve for the HIV/AIDS crisis, we will be able to do this. Next, the next reason is under international relations. The negative claims that the affirmative team will not be able to increase international relations, that we merely consult with other international organizations. But if you look to the text of the bill, it specifically calls for coordination with these other countries, such as the African Union, the European Union, and the World Health Organization itself. So by doing this, we will be able to increase our United States image and be able to do this. Next, also under international relations, they talk about how PEPFAR has hurt our international relations. But once again, we are not doing what PEPFAR is doing in the status quo. We are doing something completely different, which will be able to solve for PEPFAR's shortcomings in the status quo. So clearly, we will be increasing and improving the international relations we have. Next, the negative team claims that there will be an escalation of proxy wars. However, this is untrue because right now, PEPFAR is going into Ethiopia and providing them with aid, and it has not escalated these proxy wars, and it has not done anything to escalate wars. So clearly, we would not be escalating wars if we give this aid to Ethiopia. So clearly, we won't be doing that as well. So going over the major things in today's debate is which policy option is going to make a substantial impact, and our policy option is going to make the most substantial impact because we provide for this infrastructure, we provide for these clinics and these doctors and retainment of healthcare workers. Only doing this will we be able to make the policies that we have in sub-Saharan Africa more effective than what they are doing in the status quo. We will be able to increase the amount of people that we get to treat and increase Africans' ability to help themselves by providing Africans doctors to be able to treat their own people and have them stay in their country and their own region to help themselves. They will be able to provide more assistance and more HIV/AIDS assistance to the people, and will be making a substantial impact in sub-Saharan Africa. So clearly we are topical in today's debate, and we are making the best impact for sub-Saharan African people. When you look at vote affirmative.
Kahuku Intermediate and High School of Hawaii on the affirmative. Bellaire High School of Texas on the negative. Thank you and congratulations.
Great job, everybody. Great job, everybody. Is this on? Can you hear me? Thank you very much to our moderator, to our judges, teams. Great job, Kahuku and Bellaire. We appreciate it. Just a reminder to join us back in this room in about 20 minutes at 12:30 p.m., where we will announce the results of our 2 semifinal debates and tell you which of our teams will advance to this afternoon's NPPF finals. So we'll see you in 20 minutes back in this room. Thank you, and congratulations again.